Good day to you all. One of the most important things or the first things we do when a patient walks into your dental OPD is record your medical history. Now, most of us don't realize the exact importance of recording this medical history and the importance it holds in the management of that particular patient, and where be it the diagnosis, be it the prognosis, or be it the total management, overall management of the patient, the medical well-being or the general well-being of a patient is very much important for a dentist. So in today's session, what I'm going to do is I'm going to talk about one of the most important systems of the body which have a direct link to the oral health, as well as the problems faced by the patient, as well as the treatment which is meted out to the patient by a dental physician. Among this, one of the most and the closest link between oral health and the general well-being, the key lies with the cardiovascular systems and the respiratory systems. So why do we need to know about the general well-being, or to have a general idea about the various systems before we go in to treat the particular patient? Now, the various reasons which can be listed out, the first being few of the diseases which manifest in the oral mucosa have a direct link with the general health being and the general problems faced by the patient. As in, some of the most important diseases which are related to the CVS and the respiratory system have a salient or typical signs and symptoms which are seen in the oral mucosa. So, as well as during the treatment of the patient, if at all the patient comes across with any particular emergency. Now, this emergency might have a link to the general state of the patient, and the oral physician needs to know how to overcome this particular emergency during the treatment of that particular patient. Now, also, since the management changes for the particular patient, also the treatment strategies have to be slightly modified for these patients so as to take into consideration the general well-being or the problems which are faced by the patient. Now, the treatment considerations also include the medications which are given to the patient. Now, we all know that the medications which are given for oral diseases or affecting the oral and the maxillofacial region are kind of limited, but when these medications are taken into consideration along with the medications which are given for any other systemic disease faced by the patient, then the treatment strategies as well as the medications which are meted out to the patient totally differ. So the question arises, why do we need to record the medical history when we are treating a patient who has a problem in the oral and maxillofacial region? The answer lies in all the three aspects which are needed to successfully treat a particular patient. The first, starting with the diagnosis. Now, take for example a particular patient who has come with a bad breath. His chief complaint is malodor. And now, you might be thinking that it is a simple gingivitis or a periodontitis, and you will treat the particular patient giving a normal chlorhexidine mouthwash or any other antiseptic mouthwashes which are available in the market. Now, is the person totally treated? The answer is it may or it may not help the particular patient. Now, the main reason behind oral malodor, there are n number of reasons which result in oral malodor, and most of those reasons are directly linked to the systemic condition of the particular patient. Now, take for example a patient who has come to your dental department. The patient is around 50 or 60 years. And he's taking medications for some renal disorders. Now, this particular patient comes with a chief complaint of oral malodor, but the underlying cause for this oral malodor lies in his medications which are given to treat his renal complications. Now, as in, the oral physician needs to know what is the exact problem which the patient is suffering from, and the medications which he is giving. Now, most of the renal complications result in some a condition called uremic frost, which results in the oral malodor. Now, this is one of the main causes for a person coming up with halitosis, also called as oral malodor. So, taking into consideration this particular condition of the patient, and then treating out trying to diagnose this particular oral malodor, wherein instead of giving a simple diagnosis of oral malodor, you give a diagnosis of oral malodor secondary to renal complications. Now that would be your total diagnosis. So directly your medical history is helping you to come out with a final diagnosis in this particular case. The same thing applies to take this particular scenario a little forward and then try to find out what is the prognosis of this patient as well as the management protocol meted out to this patient. Now the same example holds good. Now if you give a chlorhexidine mouthwash or any antiseptic mouthwash without taking into consideration the renal complications which the patient is undergoing, your prognosis will be short-lived. Now as long as you use the mouthwash, the patient will be okay with the symptoms. There will be less severe symptoms in the particular patient, but once the your mouth rinse or a mouthwash is stopped used, the patient stops using the particular mouthwash, then the problem recurs. Now in such a case, if you take into consideration the renal complications and then made out a particular treatment strategy or a management protocol for the patient to deal with both the oral halitosis as well as the renal complications and the link between these two, then both your prognosis, your diagnosis, your prognosis as well as the management protocol or the treatment protocol which you give out to the patient will totally help the patient to deal with the particular chief complaint. So this is the exact link between medical history as well as the oral complications and how it helps us in satisfying the patient to his utmost full. So one of the closest links between the oral health as well as the systemic well-being lies in the cardiovascular diseases. Among all the systems in us, perhaps the closest association or the strongest link lies in the cardiovascular system and the oral health as well as the respiratory system and the oral health, which I'll be talking about today. As you know, cardiovascular system, cardiovascular diseases as such is one of the most potent killer in the modern times or in the recent times, even more than your dreaded cancer or HIV or any other diseases which are known to mankind as of now. So this cardiovascular diseases, it accounts to about 47% of all the deaths annually, when compared to just 22%, almost half of it, which is caused due to cancer or HIV, which is even more less. So this CVD, cardiovascular diseases, is a conglomerate of various conditions, starting from a simple hypertension, which almost all of us develop at some point of time, along with other conditions like arrhythmias or tachycardias, bradycardias, your coronary artery disease, or your simple myocardial infarction diseases or ischemias. So this is basically a conglomerate of many diseases which affect the cardiovascular system, and the total group is given a name called CVD. Now in this session we'll be more concentrating more upon the oral complications or the dental considerations of these diseases which are necessary for the dental physician, rather than getting to know more about the disease itself. And even if you speak from the exam point of view or a study point of view or from the practical practice point of view, it is more necessary to know what are the oral complications of these diseases and how these diseases will affect your diagnosis, will affect your management protocol, will affect your treatment protocols, and how it directly affects your prognosis, even to the extent how these oral complications directly help or hinder the treatment you met out to this patient. So in cardiovascular diseases, one of the most common condition, that is your hypertension or high BP, which if you know in layman terms. So according to CDC or American Dental Association, hypertension is defined as any condition wherein your systemic blood pressure goes more than or equal to 140 millimeters of mercury, and the diastolic blood pressure, also known as DBP, is greater than or equal to 90 millimeters of mercury. Now if you see the statistics which is accumulated over the last 10 years by the CDC and the ADA, you see as the age increases, the incidence of hypertension also increases, more so drastically within the middle age groups, starting from the 20-25 years up to the 40-45 years, that is where the incidence of this particular condition increases drastically. More so in the recent times because of the changing lifestyles or the changing eating habits or the more stress related work which we do, and the incidence of hypertension is drastically increasing in this middle age groups. So moving over to the classification which is given by the American Dental Association as well as Burkitt's Burkitt's textbook of oral medicine. The hypertension is divided into 3 groups, starting with the pre-hypertension, stage 1 hypertension and stage 2 hypertension. Now in the pre-hypertension, as you can see in the graph given, it ranges, the SBP ranges from 120 to 139 millimeters of mercury, as well, whereas the DBP ranges from 80 to 89 millimeters of mercury. Whereas stage 1 and stage 2, the SBP ranges from 140 to 159, whereas the stage 2 is more than 160. Coming over to the DBP, it ranges from 90 to 110, your stage 1 hypertension, and 110 to 120, which is grouped under stage 2 hypertension. Now, there might be few cases wherein the SBP increases more than 180 or the DBP increases for more than 120. Now, this particular condition is quite rare in the general population, and a term called malignant hypertension is given to this condition, which is secondary to some other systemic conditions. Again, your link between the importance of knowing the systemic diseases as well as the oral health. So this malignant hypertension is quite rare, and that particular term is given to any condition wherein the SBP increases above 180 to 200 and the DBP goes above 120. So what are the risk factors? We just brush through the risk factors for hypertension. Anything and everything related to sedentary lifestyle. The recent modern times, whatever lifestyles or habits related to modern times is directly has an effect on the hypertension, and then they are the risk factors known at present. Starting with your smoking or diabetes mellitus or age above 60 years. Now, how does smoking result in hypertension? Now, smoking induces the production of many antioxidants or oxidative species, superoxidative species or super free radicals, which are produced due to smoking. Now, these free radicals or oxygen free radicals, which are known as, which destroy the inner lining of the endothelium or the blood vessels, and this destroying of the endothelial lining results in small irregularities in the endothelium, which directly disturbs the flow of blood within the circulatory system. And this disturbance of blood within the circulatory system results in the deposition of these micromolecules or microatoms of lipid molecules at those irregularities, and they gradually increase accumulating over there, which gradually decreases the lumen of the blood or circulatory system. So as in physics, when the circumference or the diameter of a particular transporting media decreases, with the volume being constant, the pressure increases. Now take for example a liter of water going through a pipe of a diameter say about 1 inch. The pressure which is exerted by this particular water upon the pipe, say it is around about 20 pascals. Now if we decrease the radius of that particular tube and make it around ½ inch, the same volume of water in the given period of time, if it has to transverse through that particular length, the pressure increases triple or 4 times that of the pressure which is seen in the former case. The pressure which was 10 pascals increases up to 40 pascals. Now this is directly applicable to the circulatory system itself. When the lumen of the endothelium or lumen of the blood vessels is a constant or a normal optimum level, the pressure or the pressure which is exerted by the blood upon these walls is nothing but your blood pressure. Now when this lumen gradually decreases because of the deposition of lipids around the endothelium, the diameter decreases, the pressure directly increases. That increase in pressure is nothing but your hypertension. The same thing with diabetes mellitus. In diabetes mellitus, there is a dysregulation of glucose sugar levels. Now, this directly results in a malfunction of the Krebs cycle and the glycolysis, which wherein the energy production cycle directly goes to the lipid productions, and there will be a lot of lipid molecules which are broken down and used for energy purposes. And these lipid molecules, gradually the level of these lipoproteins or lipids gradually increase in the bloodstream, and that increases the viscosity of the blood which flows through the circulatory system, and this increase in the viscosity disturbs the streamlined flow of the blood within the circulatory system, and that directly results in the deposition of lipids in the endothelium. Now, that also decreases the diameter and directly increases the hypertension. So, that is a link between diabetes mellitus and your hypertension. The third factor being the age. We all know, as I showed you in the graph, wherein as the age progresses, the circulatory system starts to collapse, thereby decreasing the diameter, again increasing in the hypertension. So, as the age increases above the fifth or the sixth decade, there is a natural onset of hypertension in the elderly. The same holds good for male sex. The reason being the lifestyle habits which are associated with more with the male gender, your smoking or your tobacco usage or your drinking or alcohol usage, or even the incidence of diabetes mellitus is more in males, wherein there is an indirect link between diabetes mellitus and the male gender. So, obviously, taking into consideration the lifestyle habits, the stress undergone by working class of male gender, there is more, the incidence of hypertension is more in the male gender when compared to its compatriot. There is also a few conditions, all conditions which directly result in the malfunction of lipid balance within the body, or also known as, the term which is given to this conglomerate is dyslipidemia, wherein all the breakdown processes as well as the formation process of these lipid molecules, there is a constant balance which is present within the body, and any disturbance in this balance, wherein there is either a decrease in the lipid storages or increase in the lipid breakdown, which is also known as dyslipidemia, there is direct sequelae of this particular condition is increase in the lipoproteins and also hypertension. And obviously, there is also established genetic fact, or a genetic you can say a link between the hypertension, the progression of hypertension, also or the onset of hypertension in your progeny, because of the genetic link between hypertension as well as this particular condition. So, in the modern times, what is seen is the incidence of hypertension is slowly progressing towards the second or the third decade rather than the fifth or the sixth decade, primarily because of the changing lifestyles of the general population, and also the increase in the genetic effect which is seen from the in the progeny or the successive progenies. So, that is also one of the most important risk factors for the onset of hypertension. So, moving over to the dental considerations, how this measurement or knowing your hypertension is directly related to the treatment protocol of meted to a patient. Now, the blood pressure settings which is normally recommended is to measure the BP which measurement of BP is mandatory for every patient when it is his first visit. On the subsequent visits, depending upon the stage of hypertension the patient is, or the presence or absence of target organ damage, or presence or absence of any other undiagnosed or risk factors which the patient has, or presence or absence of any family history. So, basically, evaluation of the risk factors, the present condition, as well as the measurement of the BP decides at what frequency do we check for the BP on the subsequent visits of the same patient. Now, if we see a patient with pre-hypertension or stage 1 hypertension, every year the patients with BP with in the range of stage 1 hypertension, every year it is mandatory he gets his blood pressure checked. And for patients with stage 2 hypertension or around more than even the stage 2 hypertension, every visit the patient has to go for a mandatory blood pressure check, wherein your dental treatment, your elective dental treatment or your surgical dental treatment varies. So now the treatment for patients with elevated blood pressure, now if the patient is asymptomatic, the patient shows no signs of any blood pressure, or he has the patient doesn't know he is a hypertensive patient. In such cases wherein the BP is around less than 160 by 100 and there is no target organ disease, there is the dental modifications as such, be it any kind of dental modifications, are not necessary for these patients, where a patient is asymptomatic and there is no target organ disease and the BP is less than 160 by 100. Now if the blood pressure is around 160 to 179 by 100 to 110, that is in the range of stage 1 hypertension, the patient is asymptomatic, he doesn't have any symptoms, no headaches, no increased frequent urination or increased headaches or increased sweating. So all these when these symptoms are absent in this particular patient and there is no history of target organ disease also, then these patients can go for an elective dental treatment. Now if the patient has any target organ disease, or if the patient is symptomatic, or if the patient has BP more than 180 by 110, now in these cases even elective dental treatment is not meted out to the patient, wherein the BP is controlled back to the original state, at least around the stage 1 or the stage 2 area of the of your SBP by DVP. Only after that the elective dental treatment is meted out to such patients. In if the blood pressure goes above this 180 by 110, no elective dental treatment or no invasive procedures are to be given out to the patient. Now the reason being why ADA has recommended these particular recommendations for elective dental treatment or not, because stress plays an important part in the person progressing into hypertension or not, or person triggering an episode of hypertension if during the process of a dental treatment. Now since stress plays an important part and dental treatment is a stress related procedure, so to prevent any particular episode or to prevent any triggering of any particular episode of a hypertensive attack or its side complications, these particular recommendations have been put forward by the ADA. So basically what our oral physicians have to be aware of the medications which are given out to these patients in hypertensive patients is, do the medications which you give for an oral disease or an oral condition have any systemic side effects, or do these systemic side effects have a direct link between your cardiovascular diseases or the symptoms or signs of symptoms or the complications which are produced in a patient with hypertension. Do these medications aggravate that particular condition? Now this particular link has to be known by the oral physicians before giving out or prescribing any particular medications in these patients. So the interaction of these medications, the oral medications as well as the medications which are given for hypertensive patients, have to be taken into consideration before prescribing your standard drugs. And also the intraoral changes. Now we all know that there are many number of drugs or medications which are given for hypertensive patients, and each have their own set of side effects or complications. Now these complications, most of them are directly related to the oral health itself. So we have to take care that what medications or what medications we provide to the particular patient, they should not be aggravating the condition which is already seen because of the long-term use of antihypertensive drugs. For example, if you see the diuretics, which are one of the most commonly used medications for hypertensive patients, one of the most important complication of diuretics is oral dryness or xerostomia. Now, in such a case, if you give a particular medication or any medication related to the oral condition, for example, if the patient comes with an autoimmune disorder, or say a pemphigus or a pemphigoid of the oral mucosa, the standard line of treatment for a patient with autoimmune diseases is your corticosteroids. Now, take into consideration a patient who is around 40 to 50 years or the fourth or fifth decade, and the patient is on long-term diuretic usage, and because of that he has extreme xerostomia. Now, in these patients come up with the autoimmune disorders, you have two-pronged, you have a choice of giving either the corticosteroids or any other immunosuppressants like azathioprine. Now, if you take into consideration the long-term usage of diuretics in this patient, and the patient's already extremely dry oral environment, you prevent the usage or you avoid prescribing your corticosteroids to these patients, since one of the most important complication or oral complication of usage of corticosteroids is xerostomia. So, to prevent the aggravation of this condition, you don't give corticosteroids and start prescribing the secondary line of immunosuppressants, that is azathioprine or a cyclosporin or any other immunosuppressants, wherein the oral dryness is not to that extent when you are using a corticosteroids. So, this is what I meant by the interaction of the medications of your oral diseases and the systemic diseases taken by the patient have to be taken into consideration before prescribing the medications. Same goes with your adrenergic inhibitors or your direct vasodilators. All of them have a specific group or a typical side complications, side effects which affect the oral mucosa, most importantly being your xerostomia itself. So, if you see the adrenergic inhibitors, one of the most important side complication is again oral dryness as well as oral ulcerations. Now, calcium channel blockers, you have gingival overgrowth. Now, in patients who have severe gingivitis or periodontitis, wherein already the gingiva is swollen up to such an extent that there is a grade 3 mobility or grade 2 mobility of the teeth. Now, in these patients, if you give calcium channel blockers, the aggravation of this, the side complication of this calcium channel blockers being gingival overgrowth, the maintenance of that gingiva in this particular patient becomes even more difficult if you give calcium channel blockers to a patient already with severe periodontitis or gingivitis. Same holds good for AC inhibitors. One of the most important side complication of the oral mucosa again becomes your loss of taste and the lichenoid reactions of the oral cavity. So, a patient comes with a lichen planus, or a female patient, 40 to 45 year old or 40 to 50 year old female patient comes up with a lichen planus type of lesion. Now, the patient is severely diabetic, the patient is hypertensive. Now, the patient is has severe lichenoid reactions within the oral mucosa. Now, instead of giving immediately prescribing corticosteroids or any immunosuppressants to this particular patient, which further aggravates the xerostomia status of the patient, if you know that the patient is on a long-term use of AC inhibitors for a hypertensive condition, we can bring out a link between the involvement of this oral mucosa and the appearance of these lichenoid reactions we can link those glycanode reactions with the usage of AC inhibitors. So in these conditions, instead of giving out the corticosteroid, prescribing the medications, if you stop the usage of AC inhibitors, change the class of drugs to any other class of drugs such as diuretics or adrenergic inhibitors or any other vasodilators, we can stop the progression of these glycanode reactions, also avoid the usage of corticosteroids, and thereby prevent aggravating the oral condition of the patient. Moving on to the next condition, one of the most common condition apart from hypertension is a coronary artery disease, in common layman terms known as heart attack or myocardial infarction. Now this is one of the most important killer diseases among the different conglomerates of diseases which are present or which come under CVDs. Coronary artery disease is the most important killer. Now the etiology again is directly related to the various risk factors, the same as those for hypertension. But the most important process which is responsible for a person coming up with a myocardial infarction is the process of atherosclerosis. Now this atherosclerosis is responsible for almost all the cases of CAD, wherein if you see the diagram, the most important effect or the most important principle by which the blood flows within the circulatory system is a streamlined flow of the blood, wherein the heavy molecules or the corpuscles, the red blood cells or the WBCs or all these cells do not come in contact with the walls of the circulatory system or the walls of the blood vessels, wherein they flow in a streamline in between at the core or the center of the lumen, so that there's a prevention of any contact between these corpuscles to the endothelial. Now any condition which disturbs this particular flow, or there is contact between these red blood cells or the WBCs to the endothelium or of the blood vessel, since these RBCs are very sticky, or on the surface of these RBCs there are few molecules which stick to or they attract to the endothelium cell linings. These it is important to maintain this particular streamline flow to prevent any blockage or thrombosis or embolism in any particular condition. Now what atherosclerosis does is, because of the changing lifestyles or the changing habits, or because of any condition which disturbs the balance of lipid levels in the blood, there is increase in the amount of viscosity in the blood because of the increase in the lipid content, be it your VLDL or the LDL or HDL, be it any kind of lipoproteins. Any increase in these constants increases the viscosity of the blood, thereby pushing these corpuscles towards the periphery of the flow. So there is the flow of blood within the circulatory system is no longer a streamlined flow, but it is a more haphazard kind of flow, wherein the corpuscles are distributed all through the diameter, and there is an increased chance of these corpuscles coming in contact with the endothelial. Now as the streamlined flow gets disrupted because of the viscosity, there is gradual deposition of these particular corpuscles or the lipid content within the blood on the walls of the endothelium. As time progresses, because of the deposition of lipid molecules on the endothelial lining, there is a gradual deposition layer by layer, which gradually decreases the radius of the lumen. As we said, this also already increases the blood pressure of the patient, thereby the patient is already hypertensive, and because the patient becomes hypertensive, the streamline flow becomes even more haphazard, and the deposition of lipid layers in the endothelium gradually increases. Now as time goes by, this deposition increases to the level at which there is almost minimal amount of opening for the blood to pass through the lumen, and there is gradual closure of this the lumen, wherein there is a complete blockage of the lumen to the blood flow, and this particular condition is nothing but your myocardial infarction. The total stoppage of blood flow to the particular heart muscle because of this atherosclerosis, or because of the blockage of this total lumen by the lipid molecules, that itself is called as myocardial infarction. Now the next sequelae of this myocardial infarction is the breakage of this particular atherosclerotic plaque, which we call, which progresses from a fatty streak, gradually it becomes a plaque and total blockage. Now as it becomes a big bolus of lipid molecules over there, there's at few times there is a breakage of this molecule because of the force of the blood which flows through the circulatory system, and small parts of these particular plaques get disseminated all through the body, as and which progresses into an even more dangerous situation, that is your thrombosis or embolism. So this being the what you call this called as atherosclerosis timeline, which is seen in this particular condition of myocardial infarction. Again, the risk factors being exactly the same as those responsible for hypertension, since coronary artery disease is nothing but the next stage of hypertension. The risk factors are all the same. As you can see, the risk factors, lipids, one of the most, it is the most important factor in the production, in the producing this particular disease, since it is the lipids or the dyslipidemia which is mainly responsible for the production of that fatty streak as well as the atherosclerotic plaque, which ultimately ends in myocardial infarction or thrombosis. Now, apart from that, you can see the hypertension, which is the prerequisite for the production of myocardial infarction in a particular patient, along with diabetes mellitus, and as I said, smoking or lifestyle or habits, anything and everything related to sedentary lifestyle or unhealthy dietary habits or unhealthy lifestyle habits, all which directly result in hypertension, will ultimately result in coronary artery disease as the time progresses. So what are the dental considerations of this particular condition? Now this is very important. Now as I said, one of the most important vital sign which is recorded during the medical history is your BP and heart rate. So the determination of these vital signs is prerequisite to all the patients, especially if the patient is within is more than the 4th or the 5th decade. Now since this is also anxiety related, as I said, anxiety increases, anxiety or stress increases the oxygen free radicals. There is a direct link between production of superoxide species or oxygen free radicals or oxygen highly reactive species of oxygen and stress, and these reactive species directly disturb the endothelial lining or damage the endothelial lining, which thereby disrupts the streamline flow. So basically the main culprit being your anxiety or stress, that has to be controlled over here. Now since dental treatments, most of the surgical or invasive dental treatments are stress related, or wherein the patient has to cope up with the stress related to these dental treatments, it is mandatory to reduce the anxiety or the stress of the patient, especially those patients at risk for developing coronary artery disease. Now that and that also reflects upon the timing of your dental treatment. Now if a patient with say stage 2 hypertension, or who has a very sedentary lifestyle, or he is very much stress prone to or anxiety prone to, and he is highly anxious about the dental treatment. Now in these such type of patients, the treatment should be done only in the early mornings or in the before noon times, because as the day progresses, the anxiety or the stress level increases gradually. So preferably the timing of dental treatment should be in the early morning or the noon timings. So as I said, to reduce the probability of triggering a anxiety related effect or in a hypertensive patient, we preferably give the appointments to such patients in the early morning or early noon timings, so that the reason being, as the day progresses, your anxiety levels or the stress levels or the body the physical work which we do increases the stress level or the anxiety levels. So late in the evening or in the early mid evening or the night times, the stress level is at the peak, wherein if you mete out a dental treatment to these stress prone individuals, there is always a risk of developing a hypertensive or a CAD attack. So that being said, also the elective procedures, any elective dental procedures which involve any invasive procedures have to be which require general anesthesia should be avoided for at least 4 weeks following the first attack. That being said, there are many studies which tell that after the first myocardial attack, within the first month, that is the first 4 weeks, there is an increased incidence, or there is a probability of more than 60% of the person coming down with a second attack. So to avoid any such bad attacks in the first 1 week, any procedures wherein we have to use a general anesthesia or any elective dental procedures or surgical procedures involving any minor surgeries or major surgeries have to be totally avoided within the first 4 weeks after the person has come up with the first myocardial infarction. So one of the most the primary treatment line for the patients with a risk of MI, or patients who have already come up with an episode of acute myocardial infarction, the primary line of treatment which is meted out is your antiplatelet or your antithrombin therapy. Now, why this is important when we are dealing with the oral diseases? Now, if we take into consideration the first antiplatelet therapy, the normal antiplatelet therapy which is meted out to the patients is aspirin. So this aspirin, it acts as an anticoagulant, it acts as an antiplatelet factor, wherein it reduces the coagulation of these platelets, so that there is the viscosity of the blood gradually reduces in these particular patients, and there is a decrease in the triggering effect, or decrease in the probability of triggering a myocardial effect. So if we go for any particular invasive surgeries wherein the usage of scalpel is mandatory. Now, since the patient is already on antiplatelet therapy, since we are trying to decrease the effect of coagulation of the blood. Now, if there is always a chance of increased blood loss or increased bleeding time and decreased clotting time if we go for any invasive surgeries. So, in these cases, when a patient is on a long-term antiplatelet therapy, but there is an elective dental treatment which is an invasive procedure, we have to stop the usage of this antiplatelets at least 3 to 7 days prior to the surgery. Now, this particular concept of stopping the aspirin 3 to 7 days prior to the surgery is slightly contentious, but for all practical purposes, we do say that we have to stop antiplatelet therapy or aspirin at least 1 week prior to any particular dental surgeries. Now, in case of an emergency surgery wherein the patient, we couldn't have stopped the usage of aspirin 1 week prior to it in any emergency conditions, especially when the bleeding time is about 15 to 20 minutes, we can always go for a DDAVP injections, also known as 1-dis-amino, 8-D-arginine vasopressin. Now, this is given intravenous, which is actually countereffects the effect of aspirin, thereby decreasing its antiplatelet activity. This has to be given at least to the dosage of 20 to 24 micrograms at least 1 hour prior surgery IV. The other mainline treatment which is meted out to these patients is antithrombin therapy, which the basic principle again lies in decreasing the coagulative property of the blood, so as to maintain the thinness or the decrease the viscosity of the blood flow within the circulatory system. Now in these particular patients, there are 3 protocols which are followed in recent times. Different people or different researchers have promoted the usage of one or the other protocols. Now what are these protocols? The protocol 1, warfarin, which is a mainline therapy as an antithrombin agent, is discontinued totally before the start of any particular dental invasive treatment or any dental treatment requiring surgical procedures. Now the protocol 2 is warfarin therapy is discontinued at least 2 to 3 days prior, and no alternative anticoagulation therapy is given. Now this is not supported by most of the researchers, but still the protocol holds good as far as ADA is concerned. So, but the most commonly used protocol is your warfarin therapy is discontinued 2 to 3 days prior to it, and instead of that there is an alternative anticoagulative therapy which is given, that is your heparin. Now heparin has the same effect as that of warfarin. The only difference between heparin and warfarin being the half-life of that particular medication. Now warfarin has a long half-life, so even if you stop the warfarin, say about 6 hours or 12 hours before the onset of the treatment, its effect still remains by the time we start the surgery, since the half-life is more than 6 to 12 hours for warfarin. Now the same condition, if in the same condition, if you use heparin's half-life is around 5 to 6 hours. So you discontinue warfarin at least 48 to 72 hours before the surgery, and then you replace the patient with heparin and keep using it until say about 6 hours before the surgery. So exactly at the point of time at which your surgery commences, there is no anticoagulation effect of the medications which is given out to the patient, as well as the patient has a minimum time period within which he can develop any complication for this of anticoagulative therapy. So we are decreasing the probability of any secondary triggering any effect, triggering any attack, decreasing the probability of that, as well as we are also making sure that there is no increased bleeding time because of this particular medications. So this is the most commonly accepted protocol which is followed till date. Now all these protocols, whichever we follow, depends upon your INR value. Now this INR value is nothing but internationalized normalized ratio. Now this INR value is it is also called as international sensitivity index, which is or specific thromboplastin index, which is used. This test determines the type of protocol or the necessity of following a particular protocol in any dental patient before going for any minor dental surgeries. Now this INR value ranges from a value of 2 to 4.5, and if in case of any minor surgical procedures, now if the INR is below an optimum value, say about 3, which is midway between 2 and 4.5, now if the INR value is less than 3, in cases of any minor surgical procedures like simple extractions or simple flap surgeries, there is no need to discontinue the warfarin therapy or the present anticoagulative therapy which is being meted out to the patient. That being said, if the INR value is more than 3, it is mandatory we follow the protocol which is protocols which I have just talked about. Now leaving aside minor surgical procedures, any major surgical procedures, even though the INR is below 3, we have to follow the protocols so as to minimize the risk of triggering any particular coronary disease effect. So what all are the, if you list out the different points which we have to consider before following a particular protocol, you can see the underlying medical condition being the most important consideration, followed by the type of medication, again which I have told you, depending upon the different side effects of different medications, the level of anticoagulation, which is again determined by INR. The timing of dental care, which I said to avoid in the late evening or the night times. The cost, the convenience of the patient, all these effects, all these points have to be taken into consideration before following a particular protocol for these coronary artery disease patients. So that is the importance of taking into consideration this particular serious condition before starting any dental treatment for that particular patient. So moving on to the next condition, common condition is called bacterial endocarditis. Now this is just like any other infection of the general body. Only this particular infection affects the valves of the endocardium of the heart or of a particular patient, and the agents usually are bacterial. Now, why this particular infection of this inflammation of the inner tissue of the heart is different from other infectious processes? Firstly, the etiology. Etiology being streptococcus or staphylococcus, which incidentally are the most common type of organisms which are seen in the oral cavity. The secondly, the infection which is produced or which takes place in this particular location. Now this particular location is unique in its way because the blood supply to these tissues have to come from other collateral circulatory systems within the heart muscles, and these particular locations as of it do not have any separate blood supply. So any infections to this particular area, the treatment depends upon the general total health of the total circulatory system of the heart muscles or the collaterals which are present in the heart muscles, and it is highly difficult to treat this particular area because the immune system or the blood supply system is lacking to this particular area. So the sequelae of this particular infection is more drastic and more fatal when compared to infection to any other particular area. So if you have to classify this particular bacterial endocarditis, it is classified as a subacute type of bacterial endocarditis and acute bacterial endocarditis, also short for SB and AB. The difference: SB is produced by caused due to Streptococcus species, whereas AB is produced by Staphylococcus species, both of which are commonly seen in the oral cavity. Now Streptococcus, it is a low virulence type of organism, so the disease progression is very slow, which is to a lower level than the acute bacterial endocarditis, which is caused due to Staphylococcus species, which is a highly virulent organism. So the progression of this particular disease is more rapid when the etiological organism is Staphylococcus. You can see in this diagram, classic diagram showing bacterial endocarditis, wherein the valves, both the right and the left valves, are vegetations are produced in this particular valves caused due to either Streptococcus or Staphylococcus species. Now to diagnose a particular case of endocarditis, that depends upon something called as modified Duke criteria. Now what this criteria include is these Duke criteria include a list of major criteria as well as a list of minor criteria, wherein different protocols are present, where such as 2 major criteria or 1 major and 3 minor criteria or 5 minor criteria. Now if either of these particular conditions is fulfilled, given based upon the criteria which are given by Duke, then there is a definite diagnosis of bacterial endocarditis. Apart from this, there are also a couple of conditions wherein if you have only 1 major criteria fulfilled and 1 minor criteria fulfilled, or only 3 minor criteria fulfilled instead of 5, you can give a diagnosis of probable or a possible bacterial endocarditis instead of a sure shot definite endocarditis infection. Now what are these criteria? The major criteria are just 2. One, a positive blood culture with typical microorganisms, that is your streptococcus or your staphylococcus only. Now other major criteria is your positive ECG, which gives the endocardial environment, especially the walls. The minor criteria are slightly lesser typical features, such as fever greater than 38 degrees centigrade, or any predisposing factors, a previous condition or a previous incidence of bacterial endocarditis or a previous cardiac lesion. Then there is a high probability or a possibility of bacterial endocarditis. Also, there is if there is evidence of embolism or immunological problems, since the immunity, since there is no direct blood supply to these walls, there is no the immunity factors which are present within the blood do not directly reach these particular areas. So as it is in a case of a bacterial endocarditis, the immunity power which is carried by the blood hardly reaches this particular area. On top of that, if there is an overlying immunological condition which is suffered by the patient, even more drastic decrease in the immunity factors which reach this particular area. So that becomes one of the minor criteria based upon the anatomy of these valves for Duke. The final minor criteria is a positive blood culture, but without any typical microorganisms, that is a streptococcus or staphylococcus. If there are any other organisms which are present, that can be considered as a minor criteria. So depending upon these major and minor, you give a definite or a possible or probable diagnosis of myocardial and bacterial endocarditis. The treatment, as in with any other infection, it is antibiotic prophylaxis and surgical intervention if needed in advanced cases, with replacement of an artificial valve, also called as prosthetic valve. Now, what emphasis does this hold for a dental treatment? AHA has issued few guidelines upon which a person who comes up to a dental treatment with bacterial endocarditis have to be followed, have to undergo through a list of guidelines upon which we can prescribe the medications which are necessary to treat that patient. Now, if you see the AHA guidelines which are given to these patients, it is divided into oral medications and systemic medication. And oral medication and systemic medication both are further divided for adults and children. And in adults and children, again, it is subdivided as allergic to penicillin or not allergic to penicillin. It is highly very easy to remember. If we take the adults and the children, not allergic to penicillin, we give 2 grams of amoxicillin. Now, if the person is allergic to penicillin, you give ciprofloxacins like cephalexin or clindamycin 600 milligrams or 500 milligrams of azithromycin, which is a macrolide antibiotic. Now, in case of children, the same protocol is followed for not allergic and allergic to penicillin. Just the dosage is reduced by 1/4. That is, instead of 2 grams of amoxicillin, 50 milligrams per kg is given to children not allergic to penicillin. And whereas if they are allergic, we give 20 milligrams per kg for clindamycin, 50 milligrams per kg for cephalexin, and 15 milligrams per kg for azithromycin. Now, all these medications have to be given 1 hour before procedure, so as to prevent any kind of infections transmitting from the oral area to the valvular areas. Now, the same protocol or the same dosages hold good for patients who have to be given non-oral medications. The only difference being your instead of 1 hour prior to the procedure, since the effect of systemic medications is much faster, it has to be given 30 minutes prior to the procedure instead of 1 hour, which is the only difference between oral and non-oral medications. Now, what kind of oral procedures need this prophylaxis? Anything and everything which is invasive, even minor invasive or major invasive, any kind of invasive procedures which involves a scalpel or a blade, have to be given this particular prophylaxis in patients who are at a higher risk of developing bacterial endocarditis, which includes everything starting from a simple gum surgery or a flap surgery to implants or even a small intraligamentary injections. Anything which is invasive, as you can see in the list, have to be taken into considerations with patients at higher risk, and this prophylaxis have to be given according to the guidelines issued by American Heart Association. The final entity in this conglomerate of CVD, that is your arrhythmia. As the name suggests, there is an arrhythmia. Rhythm is most important for the heart rate. Now there is a disturbance in the rhythm of the heart rate or the heartbeats, that is arrhythmia. That is how the name is derived from. And obviously there is if there is an increase or upregulation of the rhythm of the heartbeat, it is called tachyarrhythmia, or there is downregulation of the heartbeat or the heart rate, that is a bradyarrhythmia. Now tachyarrhythmia primarily because of increased atomicity of the pacemaker cells or the cardiac pacemaker cells. That is the most important reason because of which tachyarrhythmia is found in patients, and the heart rates are typically more than 100 beats per minute. The normal, as you know, it is between 70 to 75 beats per minute. So greater than 100, it is tachyarrhythmia. Lesser than 60 beats per minute, that is a bradyarrhythmia. Again, the most important reason for bradyarrhythmia becomes your SAN node dysfunction or the Purkinje or the AV fibers dysfunction. So if you go for the classification of arrhythmias, it is quite simple. It is either atrial fibrillation or supraventricular tachycardia or ventricular tachycardia. You just have to know about this classification. What are the etiology of arrhythmia? Anything and everything which produces a disbalance or a lesion within the cardiac system, starting from a simple hypertension, rheumatic valve disease, your coronary artery disease, your pulmonary hypertension, anything which relates to the CV system, and even a few cases of a respiratory system such as your sleep apnea or your chronic obstructive lung disease will result in arrhythmia or will increase the probability of the patients going into arrhythmia. So what are the dental considerations? Not as important as coronary artery disease or hypertension, but still there are few dental considerations which have to be taken into consideration over here. Primary being the type of treatment which is meted out to patients with arrhythmia. Most commonly, the first line of medications which are given for arrhythmatic patients are your anticoagulant medications. Now, as I've talked before, all anticoagulant medications can be divided into antiplatelet or antithrombin medications, and the guidelines which have to be followed for antiplatelet and antithrombin medications and the INR values, I've already talked about that before. All those guidelines hold good for patients with arrhythmia, since the primary line of treatment is same as that of coronary artery disease. Now, except in cases of very acute kind of oral infections or highly emergency kind of oral infections, such as your acute oral infections, acute periapical abscesses, there is no need for antibiotic prophylaxis for arrhythmatic patients. Another most glaring misconception which is seen in arrhythmatic patients is the link between the usage of high-speed aorta handpieces and arrhythmatic patients who have pacemakers or artificial prosthetic valves. As contrary to the normal belief that these high-speed aorta pieces, aorta motors or all the equipments have a effect, electrical or a magnetic effect upon these prosthetic valves, it has been proven otherwise, that there is no link between these two, and it is perfectly safe to use these high-speed equipment even in patients who have these prosthetic valves. So that being the link or the dental considerations which have to be taken care for patients with CV systems. The next most important systemic area which has a close association with that of oral diseases or oral health is your respiratory diseases. Now, to emphasize the importance of these respiratory diseases, not only there is a to and fro passage of microorganisms from the oral health area or oral cavity to the respiratory system. There is also the effect of these respiratory diseases upon the orofacial morphology itself or even the dentition. Now, for example, if I have to give an example, we all know the one of the most common respiratory disease, that is your asthma, and also its propensity, the recent propensity to affect children younger than the second decade or the first decade. That is the most recent trend which is being followed by the this particular disease. Now, we all know that this particular this age group is a age group wherein your orofacial morphology undergoes a constant change or a remodification in this particular age. Also, your dentition is continuously there's a transition from your milk deciduous dentition to the permanent dentition. Now, in such cases, in asthmatic patients, most commonly since there is a difficulty in breathing during these episodes of asthmatic attacks, the patient starts to breathe in through his mouth. So, in these cases, what happens is, since there is a prolonged intake of breath through the mouth, there is increased amount of oral dryness or xerostomy in the patients. And apart from that, since the orofacial morphology is under modification or under changes, it adapts itself, the growth adapts itself to facilitate the easy taking of air through the mouth, as in the facial profile or the orofacial morphology becomes more dolichocephalic or leptoprosopic. If you have studied that in orthodontics, the leptoprosopic or dolichocephalic head is a longish type of facial profile or facial form, which facilitates or increases the area, the airway space area. So, the body is trying to adapt itself to take in more easy taking in of breath through the mouth by increasing the airway space, and that results in a longish kind of facial profile. Now, this particular that means to say that your simple respiratory disease is totally changing your orofacial morphology, and because of the change in the orofacial morphology, also your teeth are becoming more crowded. There are narrow arches. Instead of the V-shaped arch of the maxillary arch, there is a deep palate which is seen, narrow constricted type of arches. So everything, even your orofacial morphology or even your dentition is getting changed or adapting itself because of a simple respiratory disease. So that is how this is just to emphasize the importance of these respiratory diseases upon the oral area. Among these respiratory diseases, one of the most common seen on a everyday basis is the sinusitis. It is nothing but an inflammation of the epithelial lining of the paranasal sinuses, be it your maxillary sinus, most commonly affected, or your frontal sinuses, the second most commonly affected. In some cases, sinusitis is almost synonymous with the inflammation of the maxillary sinus. That is how common this particular condition is in the present days. Now, the etiology, very simple. All the microorganisms which are commonly seen in the oral mucosa are responsible for production of sinusitis. The main criminal over here is a Streptococcus species, apart from others such as H. influenza or Moraxilla, and any kind of odontogenic infections will directly result in sinusitis, or there is high probability of odontogenic infections spreading into the sinus spaces. Now, the pathophysiology is very simple. Now, whenever there are any upper respiratory infections or odontogenic infections or any kind of allergic irritants which are taken in, there is a direct result in the disturbance of the ciliary movement or the clearance of the secretions. Now, we all know that the tract is lined by ciliary projections and secretions which keep out these irritants or any foreign elements from going into the respiratory system. Now, because of these upper respiratory infections, there is a disturbance in the ciliary movements. Also, there is impaired clearance of these secretions. So, what it does is there is more amount of secretions which are getting accumulated within the upper respiratory tract. There is blockage of these sinus ostia or the openings. If you see the anatomy of the medial nasal fossa, we can see that there are few areas through which the secretions flow out through the nasal mucosa, basically serving as an excretory system for the nasal mucosa, that is the sinus ostia. So, because of this impaired clearance of these secretions, there is accumulation of these mucous secretions, and there is gradual blockage of these sinus ostia. So, that results in the blockage of the total osteometal complex. There is stasis or accumulation of these secretions, and wherever there is a stasis of organic rich secretions, there is always a chance of any inflammation or infection because of this pooling of sinus cavities. Now, this is the basic pathophysiology behind sinusitis. Now, obviously, with any as in with any other type of inflammations or infections, all the features of inflammation are seen as the clinical features for sinusitis. Your facial pain, tenderness, discharge, bad breath, and a headache located to that particular areas. Now, in case of chronic sinusitis, there is a slight difference wherein all these features are at a slightly lower level or less severe than acute sinusitis, and there is chronic rhinorrhea or nasal congestion and facial fullness. As I said, the sinusitis is classified as acute and chronic, and any sinusitis episode which extends for more than 1 to 2 months comes under chronic sinusitis. Now, how do we diagnose sinusitis? First, starting with your history, which is most important with any other, as in any other case, your physical examination, because most of the times your orofacial morphology gives a hint as to the presence or absence of this condition, or even a deviated nasal septum is one of the most common causes for sinusitis, which all comes under physical examination. Apart from the physical examination, there is also need for evaluating the underlying factors which are responsible, the most important etiological factors which are responsible for sinusitis, starting from allergic evaluation of for allergic rhinitis, your tobacco smoke exposure, immunodeficiency, your septal deviation. Coming out of the radiographic examinations, you have your normal radiographic extraoral radiographies such as your Waters view, most commonly used for the sinuses, especially the maxillary sinus. Your CT scan for evaluating the osteometal complex, especially in cases of chronic sinusitis, since in chronic sinusitis, because of the longer time period, there is a hazy picture which is given in the osteometal complex because of the accumulation of these secretions. Also, there is another less commonly used procedure called rhinoscopy, wherein you directly put in a scope to the posterior to view the area from the posterior nasal fossa, wherein it gives a direct visualization of the sinus ostia. Although slightly discomfortable for the patient, it is also very useful. Now you can see in the radiograph which is given, which is a classical Waters view. You can see on the right side of the maxillary sinus, the left maxillary sinus, as you can see, is radiolucent. You can see the triangular space, whereas on the its compatriot on the right side, you can see the totally hazy picture, which is due to the accumulation of a chronic accumulation of secretions within the maxillary sinus, lack of excretion of these secretions through the sinus ostia or the osteometal complex. You can see the totally radio opaque picture on the right side of maxillary sinus. You can also see the posterior rhinoscopy as in the introduction, the way of introduction, and how the scope is used to visualize the posterior, the nasal fossa from the posterior view, and also it gives a clear picture of the osteometal complex. Now, how do we manage it? As in with any other infection, your antibiotics, the mainstay of treatment for any infections. Your allergic rhinitis, as the name suggests, it is an allergic kind of inflammation or infection. So remove the allergen, and that's your treatment for allergic rhinitis. Normally, the treatment lasts from 2 to 3 weeks, and there's also something called as functional endoscopic sinus surgery, especially for chronic sinusitis, wherein it's nothing but opening up the clogged manhole, as in if you want to say in layman terms, your sinus ostia is blocked. So what happens is the functional endoscopic sinus surgery opens up that sinus ostia so as to permit the excretion or the excretion of the secretions which are seen in the nasal fossa. And apart from that, there is always avoidance of any predisposing factors like tobacco smoke and etc., or any allergens to prevent the progression of sinusitis. So what are the dental considerations? First and the foremost, the most important consideration is how do you differentiate between a simple tooth pain and a sinusitis. We all know that the posteriors, especially the maxillary molars, the roots most commonly in the general population, they pierce through the maxillary floor sinus and enters into the maxillary antrum. Now, whenever there is an involvement of the maxillary sinus in that particular area, or there is infection and inflammation over there, the pain signals get transmitted through the root canals of the maxillary molars, which pierce through the maxillary floor, mimicking a toothache. So in these cases, when a patient comes with a complaint of pain in his right or left upper molars, most commonly the dentist associates it with a normal tooth pain and suggests an RCT or extraction, wherein that is the wrong line of treatment, since it's not the pain is not originating from the tooth itself, but it is simply reflecting the inflammation or infection which is present in the maxillary sinus. In such type of cases, your medical history comes to the foremost. It is most important to know or physically examine the patient or know the medical history of the patient, the incidence of these sinusitis attacks or pain in that area, the evaluating the typical features or signs or symptoms for maxillary sinusitis, and then going on to treat that particular patient. So here again the emphasis of medical history in treating a dental patient. Now, what are the different problems which we come across in treating a dental patient with sinusitis? First and foremost, chronic sinus infections. As we have told, since there is difficulty in difficulty in breathing through the nose because of the obstruction, the patient resorts to mouth breathing. Mouth breathing directly results in oral dryness, since there is continuous exposure of outside air, and there is increased susceptibility to oral infections. Oral dryness, the saliva, the flushing effect or the cleaning effect of saliva is not seen because of the continuous dryness, and that leads to the oral infections. That is one of the most important dental consideration. Next, chronic sinusitis. There is prolonged use of antibiotics. There is always a risk of developing bacterial resistance to these particular antibiotics. So normal odontogenic infections, if you give the same kind of drugs, which are given for sinusitis, there is always a chance that there is the effectiveness of this, the potential of this particular medications is far more less when compared to other patients, because the person has already developed this particular antibiotic resistance. The use of decongestants, which is another line of treatment for treating sinusitis or blocked nose too, as to say. There's oral dryness because of this continuous usage of oral decongestants. There is oral dryness or xerostomia, again resulting negating the effect of all the important effects or all the useful effects, medical effects of saliva because of this oral dryness. You have increased calculus production, increased plaque production, increase in the dental caries incidence, increase in the fungal infections, increase in the xerostomia, increase in the any other opportunistic oral infections because there is a lack of saliva over there. So all this is a natural sequelae which is followed, which one after another everything follows because of this oral dryness. So it is highly important to differentiate or take into consideration this particular disease or disorder before going on to treat the dental patient per se. Now the next most important common kind of respiratory disorder is your asthma, wherein it is characterized by repeated, recurrent, reversible airflow obstruction. The term reversible is very important in this condition because that is what differentiates this particular condition from other type of respiratory disorders. It is a recurrent and a reversible kind of airflow limitation because of an underlying inflammatory process. Now the etiology is primarily unknown for asthma, or secondarily there must be some allergic sensitivity to that patient, and also genetic factors have been proposed to produce asthma, but largely it remains unknown. So what is the pathogenesis? Now the primary problem in asthmatic patients is a recurrent inflammation which takes place. Now every time the area gets inflamed or there is infection over there, the body copes up by producing its typical characters of inflammation, and during the process of healing, the endothelial lining or the musculature heals with scarring or slight amount of fibrosis. Now this progression of fibrosis is continuous because of the recurrent nature of asthma itself. This continuous inflammation healing, which gradually increases the fibrosis or scarring of the endothelial system or of the airway system, which gradually decreases the size of the lumen. So increasingly it becomes more difficult to breathe. Increasingly the episodes of asthma are more frequent. Now if you look at the pathogenesis itself, a chronic inflammation results in a damage and repair process. Now because of this recurrent nature of asthma, there is repeated damage and repeated healing process, which directly results in your basement membrane thickening, your basement membrane fibrosis, which results in mucus plugging and constant edema, and that results in stasis. There is bronchospasm, and resultantly there is difficulty in breathing over there, and finally there is airflow obstruction. So this is a repeated process, and as time goes by it can only get worse. So what are the clinical findings? The two most important typical features of asthma, the recurrent nature of asthma as well as the reversible nature of this disorder is the most typical clinical features in an asthmatic patient, along with the repeated incidents of damage and repair. Instigates the body to respond in a responsive way to any foreign allergen or an irritant which enters the airway passage. So there is airway hyperresponsiveness in patients, especially with chronic asthma. So there is intermittent coughing to release out to expel out the foreign objects. Dyspnea, difficulty in breathing, chest tightness, everything, all typical features related to difficulty in breathing or any obstruction in the airway passage. There is also increased anterior posterior chest diameter, which is one of the body's compensatory mechanism to increase the residual volume area, to increase the output of the respiratory mechanism. So, and also few well-defined trigger factors are present for this particular condition, such as any allergens, exercise or cold, anything which reduces the diameter or constricts the muscles responsible, or the musculature responsible for the airway passages. So typically the symptoms tend to worsen at night because of cool air and early morning areas, which is obvious. To manage asthma, it is basically a symptomatic control. Whatever the control plan which is devised for an asthmatic patient is to decrease the frequency of the attacks of asthmatic attacks, or to decrease the severity of these attacks if they take place. So the pharmacotherapy, it is basically divided into different categories. If it is mild intermittent, we give short acting bronchodilators. If it is moderate, we give inhaled corticosteroids. Now if it is moderate to severe type of asthmatic or persistent kind of asthmatic, then we give long acting bronchodilators, predominantly salmeterol and other leukotriene receptor antagonists. So what are the dental considerations? Primarily, the main culprit over here is inhaled corticosteroids and long-acting bronchodilators, because the primary side effects of these medications is oral dryness or xerostomia, and hence the long sequelae of xerostomia follows in patients with asthmatic condition. To name few, candidiasis, which is an opportunistic fungal infection, which typically is seen in immunodeficient patients. The immunodeficiency results from oral dryness over here, because your saliva itself is a first line immune defense for the body. So from there is decreased salivary flow, candidiasis, increased calculus, increased dental caries, and hence all the sequelae which follows xerostomia. So elective dental procedures should be avoided in all, except for in those patients wherein the asthma is well controlled, or the patient is in a controlled state. So also there's a need to avoid any exacerbation, because most of the dental materials which we presently use, most of them have been linked with triggering an asthmatic attack, starting from your normal dust alginates to any toothpaste, dentifrices, all these, even your normal LA which has sodium metabisulfate is known to trigger an asthmatic attack. So it is mandatory to avoid all these triggering factors and use an alternative kind of dental materials in patients who are known to have frequent episodes of asthma. So what are the recommendations? As I said, all the dental materials which are used in the normal clinical setting, which have a known link to triggering an asthmatic attack, have to be controlled, and all the medications which produce the side effects of oral dryness and all its sequelae, everything have to be contracted by using a suitable kind of contractive agent, starting from fluoride supplements or mouth rinsing with water after using inhaled corticosteroids, so as to reduce the effect of corticosteroids upon the oral mucosa, hence reduce the oral dryness. All antifungal agents, avoiding dental materials, pushing the appointments to less stressful hours, such as early mornings or early noon. So all these have to be avoided or taken care of, the recommendations for a dental treatment for an asthmatic patient. Now, if even though after following all these recommendations, a patient comes up with an acute asthmatic attack, you treat it as an dental emergency and discontinue the dental procedure immediately, and you remove all the intraoral devices, everything and anything which obstructs the airway passages, since the patient is already having a difficulty in breathing, and immediately given IV or SC kind of contractive agents for bronchodilators to contract the asthmatic attack, namely a beta 2 agonist, or most commonly used epinephrine, which is given subcutaneous to this in case of an acute asthmatic attack. The next kind of commonly seen respiratory disease is chronic obstructive pulmonary disease, also known as COPD. Now this COPD has two varieties or two subtypes, namely chronic bronchitis and emphysema. Basically, chronic bronchitis, a COPD affecting bronchi and bronchioles is called as chronic bronchitis, and emphysema is basically a histopathological diagnosis wherein there is enlargement of alveolar spaces primarily due to the destruction of alveolar spaces. So the small minute alveolar spaces get destroyed, the inner walls get destroyed, and that there's a gradual fewer and larger alveolar spaces, which decreases the surface area of respiration. So it decreases the O2 and CO2 transfer at these surface areas. Hence, there is a difficulty in breathing. Now, the most important feature which describes or typically describes this COPD is the irreversible nature of inflammation, which is seen in this case. So there's no treatment for this at present, and it is an irreversible, continuously progressive kind of condition seen in few individuals. Etiology, as in with all other respiratory diseases, there is allergens like smoking of tobacco, air pollution, and also typically for emphysema, there is a deficiency of the enzyme called alpha-1 antitrypsin, which is a protective enzyme for the alveolar walls. So the pathogenesis, straightforward. All the toxins or the whatever present in the tobacco smoke or allergens or inflammatory agents which are responsible for known as etiological factors for COPD, there is intense hyper responsiveness of the body against these insulting agents or foreign agents, and hence there is increased number of there is a hypertrophy and a hyperplasia of goblet cells. So this is the difference between other respiratory diseases and COPD, wherein there is increase in the goblet cells, there is a hyperplasia as well as hypertrophy of the goblet cells, and in few cases there is destruction of alveoli, that is a subtype of COPD. Hence it gradually increases the amount of mucus secretions, there is mucosal edema, and hence there is difficulty in breathing. So there is airflow obstruction, edema, and airway plugging. The clinical features, as with the different varieties, if it is a chronic bronchitis, there is dyspnea, cough and sputum production. In the later stages, when there is involvement of liver also, when there is liver enlargement in these patients. Now, because of the hepatic portal system, there is something called as pulmonary hypertension, which results in patients with chronic bronchitis. Now, because of hepatic portal circulation, there is an increase in the pulmonary hypertension, and because of the increase in the pulmonary pressure, there is cyanosis which is seen in these patients. So typically these patients are seen to have a bluish tinge all over the face and the neck region. That is because of the cyanosis which is produced because of pulmonary hypertension. So a synonym known as blue bloaters is given or attached to these kind of patients suffering from chronic bronchitis. That blue bloater is because of the cyanotic bluish nature, bluish color which is seen in these patients. So the other clinical features which is associated with emphysema, it is known with a synonym called as pink puffers. Primarily the pinkish nature because of the overload put on the accessory respiratory muscles other than the normal respiratory muscles by the patient. Because there is increased difficulty in breathing, he tries to take in more amount of breath in. So he tries to use all the available muscles for the respiratory mechanism to function normally. And also puffer because of the nature of his pursed lips, which try to take in air with great difficulty. The name pink puffer is associated or tagged to patients suffering from emphysema. Now another most important feature of process which takes place in emphasetic patients is the respiratory drive. Now in normal patients, what happens is there is a normal partial pressure of oxygen which enables him to take in a normal amount of oxygen, and this oxygen provides the drive for the respiration to continue. But since in these cases the partial pressure of oxygen is far more less because the number of alveoli are less, There's the diffusion of O2 and CO2 gases is less because of the lesser surface area. There is drastic decrease in the partial pressure of oxygen. In these cases, since there is a decrease in partial pressure of oxygen, there is an increase in the partial pressure of carbon dioxide. Now we all know in physiology, as a compensatory mechanism of the body, whenever there is increase in the partial pressure of carbon dioxide, it compensates the respiratory mechanism by increasing the respiratory drive by providing signals to the brain, specifically to the hypothalamus. So in these cases, the respiratory drive basically is derived from the increased partial pressure of carbon dioxide. Now why this point is important? So this point is very important because in cases wherein we have major surgical procedures to be done for dental treatments, in cases wherein we have to use general anesthesia, predominantly they use pure oxygen, which increases the oxygen tension or increases the partial pressure of oxygen in a patient with under general anesthesia. Now that might prove fatal for an emphatic patient because you are depriving the patient of the basic respiratory drive which the body has developed in an emphatic patient because of increase in partial pressure of carbon dioxide. Now since you are temporarily for that particular surgical procedure increasing the PO2 or the partial pressure of O2, you are negating the effect of partial pressure of carbon dioxide. So it might prove fatal to this patient instead of proving useful for this patient. So in these cases there is a mixture or a optimum mixture of oxygen and nitrogen given in cases of emphatic patients under GA. So now in these pictures you can clearly see the comparison between a normal alveolar structure and a comparison of an alveolar structure in an emphatic patient or a patient with chronic bronchitis, wherein you can see the lesser number of alveoli and larger number of alveoli. Also we can see the classical presentation of pink puffer, barrel chested, parallel body with thin individuals and the pinkish hue. As said, there is no cure for this disease. It is an ever progressive state. We can only try to decrease the frequency of these attacks and also decrease the severity of these attacks if they present themselves. So the maintenance therapy is basically an inhaled corticosteroid such as albuterol, inhaled bronchodilators such as albuterol or salbuterol. And during exacerbations, this oxygen therapy is often required, taking into consideration that 100% oxygen should not be used in these patients. And also antibiotics, if at all there are any acute exacerbations of this chronic bronchitis, broad spectrum antibiotics are used to treat these patients. As said, the dental considerations, there is a strong link between oral infections and the exacerbation of COPD. So maintenance of oral health is of primary importance in patients with COPD, since all periodontal pathogens or the Streptococcus viridans or Staphylococcus species have known to have a strong link between the increased aggravation of these episodes of COPD or these attacks. So it is, especially in elderly individuals, it is more necessary to maintain this oral hygiene at adequate dental care. And also, as said, increased oxygen tension primarily diminishes the respiratory function in patients with COPD. So extreme caution is advised over here. So that brings us to the end of this session